Hi, and welcome to the VieSID Press-release. In this video, we report on articles selected from the dental literature published in May 2022 that we hope might be of interest to the VieSID community. Let's begin. The Dental Clinics of North America has published a contribution by Ando and colleagues focusing on the diagnostic and treatment aspects of patients affected by neuropathic orofacial pain. Ando et al. Stress the importance of a correct management of neuropathic pain once differential diagnosis of dental pain has been ruled out. First of all, they describe neuropathic pain as pathologic pain owing to a lesion or dysfunction of the nervous system. They presented a list of parameters useful for the anamnesis of neuropathic pain and pain characteristics that can be considered red flag for neuropathic pain. They describe possible types of neuropathic conditions, including trigeminal neuralgia, trigeminal neuropathy, such as post-traumatic trigeminal neuropathic pain, trigeminal postherpetic neuralgia, persistent idiopathic facial pain, and burning mouth syndrome. Accordingly, they suggested different suitable treatment modalities. Since dentists are the first responders to patients with neuropathic orofacial pain, it is of utmost importance that they possess information for recognizing it and addressing the patient to the right specialist. In the Japanese Dental Science Review, we found a paper by Farshid Far et al. Presenting the results of a systematic scoping review on the efficacy of injectable platelet-rich fibrin in regenerative dentistry. Injectable platelet-rich fibrin, or IPRF, is a blood biomaterial obtained in non-glass centrifugation tubes at lower centrifugation speeds. It is known since 2014, and it is used in several medical applications for the acceleration of healing processes and reduction of inflammation, as it contributes to regeneration of bone, periodontal tissues, cartilage, and pulp tissues. In particular, it induces proliferation and migration of the human mesenchymal stem cells and triggers osteogenic differentiation. Additionally, it shows anti-inflammatory and antimicrobial activity. The authors managed to include 60 papers, mostly from 2020 and 2021, including both in vitro and clinical studies. Based on 22 articles, positive results for bone regeneration were obtained from in vitro and in vivo and clinical studies. For example, IPRF coating of titanium discs results in an increased proliferation, mineralization, and alkaline phosphates production. PRF improved the quality of the bone graft material in both maxilla and mandible, as well as bone formation following sinus floor elevation. 13 articles show that periodontal regeneration properties are proper to IPRF. These consisting in gingival fibroblast viability and biocompatibility, and increased migration, spreading, and surface area on tissue culture, plastic, and pickled titanium. In case studies, a significant alveolar bone gain and reduced pocket depth were reported, although there is a lack of consensus on the effect of IPRF on periodontal parameters evaluated in vivo settings. Wound healing and anti-inflammatory efficacy was demonstrated based on 9 articles revealing angiogenic activation of human outgrowth endothelial cells, success in replantation of an avulsed permanent molar, and complete remission of pain in a case of non-healing lesion. Internal inflammatory root resorption could also be treated successfully. Cartilage regeneration is among the clinical effects of IPRF. as reported by 7 articles, as a significant decline in pain scores were recorded for TMJ patients undergoing intra-articular injections due to possible remodeling of damaged cartilage surfaces. Favorable effects of IPRF on accelerating tooth movement during orthodontic treatments were also observed in 5 works. Moreover, bone and roots seem to be protected from unwanted resorption. Based on 4 articles, antimicrobial efficacy of IPRF was shown against both periodontal and cariogenic pathogens, both biofilm producers and non-biofilm producers, especially in combination with antibiotics. 3 articles reveal drug delivery potential, except when combined with a triple antibiotic mixture by integration. In conclusion, IPRF shows regenerative, anti-inflammatory, antibacterial potentials. Furthermore, IPRF is bioavailable since it's applied directly to the treatment site, and gradual release of its growth factors and cytokines increases growth over time. One of the downside of the biomaterial is that it degrades within 2 weeks, but it can be combined with albumin based on a procedure recently developed by Fujioka, Kobayashi, and colleagues for a longer lasting material. The Japanese Dental Science Review published also a review by Minakuchi et al. Focusing on management of sleep bruxism. The authors observed that although bruxism is considered a behavior rather than a pathology, it might lead to unwanted effects in case of excessive occlusal forces and thus mechanical stress conducing to tooth fracture, periodontal disease, masticatory muscles, and temporomandibular joint disorders. Thus, they analyzed the research clinical trials seeking for evidence for the best management tool available between oral appliance therapy, including maxillary stabilization splints and mandibular advancement splints, cognitive behavioral therapy, such as physical therapy and relaxation techniques, biofeedback therapy, consisting in providing the patient a signal of different sorts in concomitance with the bruxing activities, such as electrical non-painful stimuli, painful shocks or vibrations or sounds. They also consider pharmacological therapies, including proton pump inhibitors, alpha-amino acid, L-DOPA, dopaminergic agonists, tricyclic antidepressant, anticonvulsant, non-selective adrenergic beta receptor blocking agents, selective alpha-2 receptor agonists, and botulinum toxin type A. Based on 11 articles, results for all appliances were not consistent. However, efficiency in reducing sleep bruxism occurrence and intensity was shown for both maxillary stabilization splints and mandibular advancement splints, although with low certainty of evidence. Adverse events for these splints were not reported by these particular studies, but are known in the literature and include muscle and dental pain, open bite, and other kind of dental problems. The results of 3 studies on cognitive behavioral therapy did not show tangible benefits in alleviating patients from sleep bruxism. No adverse effects were reported. Biofeedback therapy was treated instead in 13 studies, but there is no evidence that occurrence of sleep bruxism could be reduced. Obviously, only the length of the bruxism events were significantly reduced. Some reported interference of the therapy with quality of sleep. The pharmacological trials showed some positive results on the reduction of sleep bruxism occurrence per hour, or on the duration of the events or peak amplitude of the bursts, depending on the drug used. However, the studies were mostly including small numbers of patients. And furthermore, no negligible adverse effects, including gastrointestinal symptoms, poor sleep, blurred vision, hypotension, dizziness, apnea, and oxygen desaturations were observed. The authors concluded that the evidence on the effectiveness of currently applied therapies for sleep praxis management is scarce and more research is required. The Journal of Dental Research published an article by Xu et al. Reviewing literature on the effectiveness of oral exercise on masticatory function in adults. Collectively, the data of 21 articles representing 18 different studies were analyzed and revealed that oral exercise can significantly improve bite forces, especially if intensive exercises are performed. Instead, oral exercises could not significantly improve mastication performance, namely the ability to more effectively comminute food. However, to evaluate mastication performance, it is crucial to control for occlusal parameters, including number of teeth or presence of malocclusion or denture. Denture was not consistently done in these papers. In the Journal of Oral Rehabilitation, we found a study by Li et al. Evaluating masticatory performance in relation to occlusal contact areas. 52 adults, 30 men and 22 women, aged between 25 and 35 years, were included in the studies. Patients had natural and complete dentition with normal occlusion. The methods used in this article are interesting for future research, provided that some limitations present in this work are overcome. The subjects were instructed to chew on 3 grams of peanuts standardized for research purposes for 10 times, and in a second session for 20 times. The comminuted peanuts were then spat out according to protocol, and then they were desiccated and passed through sieves of different thickness. So then these were analyzed and defined the particles the highest masticatory efficiency. Occlusal analyses were performed on bite registration obtained using a suitable material compatible with the bite eye device, which you see here. Occlusal contact areas were measured by the device, as well as thickness of contacts at specific intervals like 9, 29, 59, 89, and 149 micrometers. Significantly smaller particle sizes were obtained by chewing 20 times rather than 10 times, and in men, these were smaller than in females. As one would expect, also the authors found that the higher were the occlusal, so the larger were the occlusal areas, the closer the upper and lower dental surfaces, the smaller were the particles obtained through mastication. The main problem with this work is that subjects were instructed to chew with open-close movements, carefully avoiding lateral movements of the mandible. And this is an unnatural way of chewing, which, in my view, invalidated the results of this study. In the BMC Oral Health, Haladad et al. Investigated the position and morphology of the condyle in skeletal class 2 adults with mandibular retrognathism in different vertical skeletal patterns with respect to class 1 individuals. They consider ADC-BCT data in total equally distributed in some samples of 20 as hypo, normo, and hyperdivergent individuals and the controls. They measured the position and inclination of the mandibular fossa and the shape and position of the condyle. Furthermore, they measured the volume of the TMJ space. They found that the hyperdimension group had a deeper and both anteroposteriorly and mediolaterally narrower glenoid fossa than the hypodivergent group. Accordingly, these individuals possess smaller condyles, which are more anteriorly located than in the other orofacial types. With this, I conclude the presentation, and I invite you to contact us in case you want to know more about our activities. Otherwise, be ready for next press release. Best wishes to all.